All right, how's everyone doing? My name is Andres. I'm one of the chief residents, and I'm honored to introduce our guest, Grand Round speaker, Dr. Eduardo de Marchena, true quadruple cane who completed his bachelor's, doctorate, residency, and fellowship here at the University of Miami. He's the associate dean for internal medicine, professor of medicine and surgery. He's an interventional cardiologist who has published in various areas of cardiovascular medicine and structural heart disease. He spearheaded multiple key programs, including the Heart Transplantation Group and the Interventional Cardiology Training Program. He has served as the chairman of the University of Miami Medical Group, the chief of Cardiology Division, and program director of the Cardiology and Interventional Cardiology Fellowship Groups. He is also a pioneer and program director of the Eberhard Group International Structural Heart Training Program at the University of Miami Miller School of Medicine. Today, he will be discussing the impact of newly approved transcatheter procedures in treating structural heart disease. It is my distinct pleasure to introduce Dr. de Marchena to Medicine Grand Rounds.
Beautiful. So thank you so much for inviting me, and it's a pleasure to be here. It's been actually, I think, almost a decade since I gave my last medical Grand Rounds. And so it's always an honor to present to this distinguished group. So today I'm going to talk about transcatheter structural interventions and how this field, emerging field, is growing incredibly rapidly, and also to show you that the impact of international education and research in this field and the way that we can collaborate to make these things move faster. The only real conflict I have in this lecture is with Tendyne, which I was the co-founder of that company, and I'll talk about it a little bit later. So catheter-based treatments of structural heart disease encompass treatments for acquired congenital and pathologies that are, for congenital and acquired pathologies that in the cardiovascular system that affect central structures, but other than atherosclerotic coronary or peripheral vascular disease. And so it basically is procedures to treat congenital heart defects, multiple of them, also to treat corrections of surgical corrections. So after you've done complex congenital surgeries on children, they're left with abnormalities later in life, like conduit stenoses, branch stenosis, strictures, treatment of hypertrophic cardiomyopathy, treatment of acquired valvular disease, like valvuloplasty, valve repair, and multiple valve replacements, of which we'll talk about today. And then also left atrial appendage closure, perivalvular leak closure, just to give a short list. Now, being an interventional cardiologist in the United States in the 80s, 90s, and early thousands, it was very frustrating to see that our regulatory process in the US moved so much slower than it did in Europe and therefore the rest of the world. And just to give you a few examples of life-saving technologies that I didn't have available to my patients for years, drug-eluting stents were first implanted in 1999 in Brazil, approved in Europe in 2000. We didn't have approval in the US till the spring of 2003. Transcatheter aortic valve replacement, first in France in 2002, the balloon expandable and self-expanding TAVR valves in 2007, approved in Europe. In the US, they weren't approved until 2012 and 14. And the mitral clip, first done in Venezuela in 2003, CE mark in 2008, and approval in the US partially in 2013, and then full approval in 2019. Now I'm gonna put all this together. So we're gonna move around a little bit. So in 2007, we decided to launch the International Medicine Institute, and we did that for several reasons. One, there was a rapid growth of medical knowledge around the world. And with the emerging economies in Latin America, there was an expanding need for healthcare access and also for expertise. We already had the bedrock of our program, which was the Harrington Training Program with its long excellence, and all of you are familiar with this. We needed to expand our observership programs toward Latin America, Caribbean, and globally in order to help meet these demands. And we also wanted much more participation in international conferences and also to promote these conferences. There was also a demand for more medical care from international patients. And we felt that the best strategy to promote referrals to UM Jackson was with international training, academic collaborations, and research. And there was a greater interest in international research collaboration throughout the hemisphere. There was multiple institutions throughout Latin America that expressed interest in participating in clinical trial and having research training. So we formed an arm in our institute, which was our Clinical Research Institute arm. And this arm was supposed to identify sites with the desire and capability to do quality clinical research, to do clinical research education, helped by the CITY program, our medical ethics program, and then to be a conduit for medical startup companies in order to help them identify proper sites for quality research and to guide them through the regulatory process in different countries. And this has been a major success over the last decade. And you can see multiple different startup companies have gone through our institute at different sites in Latin America. Some of those have gone on to CE mark and US approval. Some of them are in clinical trials in the US. So it's been a major success. Now, changing back to transcatheter aortic valve replacement and the structural revolution, the technique that really pushed or propelled structural heart disease as a field was the transcatheter aortic valve. And this first valve was performed in 2002 by Dr. Alain Cribière in France. And the patient that Dr. Cribière treated was a 57-year-old man with bicuspid aortic valve who was dying after 3 medical teams had turned him down because of major comorbidity. He had severe peripheral vascular disease. He even had a free-floating thrombus in the LV. And he was really in a severe cadaveric state. The valve that Dr. Cribière helped pioneer was a metallic framed valve that was where a bioprosthetic valve was sewn into this frame, and then it was loaded and crimped on top of a stent of a balloon, and the balloon therefore could then be put into to place the valve. You can see how crude this early technology was for the first patient. Dr. Cribière had to do this procedure because it was the catheter was so large you couldn't put it through the arterial system. He had to put it through the venous system with a transeptal puncture through the mitral valve, and then across the aortic valve and deploy this new valve in place. And this was a major success in this extremely sick patient. This is the same patient about 10 days later, where he's already now looking with good color and feeling a lot better. Still, obviously, had been ill for quite a long period of time. And this is a sign of the times, I guess. This is 2002 with Dr. Cribière on the same day as the procedure was done. And both him and the patient are celebrating with champagne. Of course, this is France. But just think in 2002 now, me and one of my patients having champagne in the CCU at the University of Miami. So it's completely different time, obviously, but it's kind of fun to see. So this was the Cribière-Edwards valve. Was formed shortly after the initial Cribière valve. The technology was bought by Edwards, and it was propagated and changed to the devices we're using today. This is the balloon expandable valve, the Sapien S3 valve, and this is now done through an arterial approach and deployed in situ. Shortly after Edwards purchased the technology, Core valve was launched. This was a different valve. This was a valve that was made out of nitinol that allowed for the valve to be self-expanded. So instead of having to use a balloon, the frame would expand with this fabulous metal nitinol that allows it to regain its normal shape. And inside of it was a bioprosthetic valve implanted. By 2007, both the Core valve and the Edwards Sapien valve were approved for use in Europe. Now, in 2007, the partner trial was launched, which was the first valve for the Edwards valve in the United States, and University of Miami was approved to be a site in early 2008 with Bill O'Neill, Alan Heldman, Mauricio Cohen, Carlos Alfonso as co-investigators, Dr. Salerno also. And we became one of the major sites for enrollment for this trial. We also used the opportunity that the core valve was approved to see if we could launch our international research arm for the International Medicine Institute. So in the 2007s, we had already gone to Europe and observed cases. We had worked to find the proper site to do research in. And so in March of 2008, we went ahead and performed the first transcatheter aortic valve replacement in Northern South America. We were preceded by a couple of weeks by one valve done in Brazil by Eberhard Grube, who we'll mention about a little later. And this is the team that did it. We had chosen the site of Angiografía de Occidente because of the fabulous work that Antonio Dagger was doing there. Antonio is a Harrington graduate. His partner is Bernardo Caicedo. This is Steve Saldana from the original core valve. And this gentleman is Peter De Jagre, who's a major thought leader in structural heart disease, one of the innovators of the core valve. And that guy with the black hair is me. And so we were extremely happy we were able to launch this program. And this gave us access to being able to treat patients in Latin America, and also to be able to take some patients that couldn't qualify for trials and offer them a place to be able to have clinical work near us in an approved site. Because of our work in Latin America, the core valve pivotal trial was launched in the University of Miami as one of its sites. There were 50 sites in the nation. We were only one of 2 sites in the country that had both the Edwards valve and the core valve in clinical trials at the same time. Now, by the end of the decade, the FDA finally approved the Edwards valve for clinical use in late 2011 for inoperable patients, and then shortly after for high-risk surgical patients after trial had shown its utilization. So this is where we were in 2015 now. In 2015, there was the very rapidly growing number of patients that were requiring TAVR and were being treated with TAVR. It was expected there would be a 4-fold growth by 2025 in this is US, Europe, and rest of the world. And you can see that the US is very rapidly increasing its total number of cases. This slide shortchanges what the US really did, but it's still very interesting to see what the projections were. So we knew that if we were going to be training individuals to do these procedures, they had to develop many, many skills. They had to be able to do very complex planning using CTA in order to look at the valves, the structures next to them, looking at the relationship with the coronary arteries, looking at the vasculature and how to be able to get to the heart through arterial access, through venous access at times, and through other alternative accesses at times. And they also had to develop a bunch of other skills for other interventional techniques, such as intracardiac echocardiography. They had to become very adept at reading and even doing transesophageal echocardiography, 3-dimensional imaging in transesophageal echocardiography, MRI for planning structural cases of ASDs, large vessel access and closure, peripheral vascular interventions to treat complications of the procedures, and proficiency in a wide use of wires, catheters, valves, and devices. When we looked at how well we were training individuals, we started first looking at this in 2012. This was a publication in Catheterization and Cardiovascular Diagnosis looking at the US. This is the same year that TAVR was approved in the US. And in the few sites that were treating patients, fellows for structural training, they weren't really reaching the numbers that they required for what we considered you needed to do to develop proficiency. And these were very modest numbers for proficiencies. Here in Canada in 2015 and Europe in 2016, this is almost a decade after they had approval, they had enough cases to reach proficiency in TAVR, But if you look at multiple other devices, they really didn't have the adequate numbers to reach proficiency in those either. So no specific center was giving enough exposure for all the different areas of structural heart disease. So we said, how do we form a structural heart disease program that will meet the current or the future demands? And so we thought that the best way to do this was to facilitate contribution between countries with different regulatory agencies, different access to technology, for, in our case, to preserve the quality of our interventional cardiology program at Miami, Jackson, and VA, to provide enough experience for our fellows to become independent operators in a broad spectrum of structural heart disease interventions, and to have exposure to new innovations and the creative process. And we wanted to expose the fellows to give them an opportunity to establish friendships with major thought leaders. So the three amigos got together again, and with the help of our first structural fellows, we conceived of a training program that would allow us to be able to train in three different continents. So the bedrock of this would be the University of Miami Health System, also helped by the Erasmus Center in the Netherlands, and the Angiografía de Occidente in Colombia. And this is the training program we came up with: 9 months at the U, one doing clinical and research, 1 month at the Erasmus Center doing research and imaging. The Thorax Center was one of the novel places for major structural imaging, and we wanted to have them help us with this, plus also many new technologies were being tested there. Angiografía de Occidente for clinical and research, huge clinical site with tremendous regional referral, and so it gave great numbers of exposures for the fellow in a wide variety of techniques. So this gave the fellows structural exposure in multiple different devices. It gave them adequate case numbers. In most of the devices, it gave them structural imaging training, exposure to world-renowned operators and thought leaders, exposure to national meeting organization. They helped organize the Miami Valves Conference, exposure to new device development, clinical research trials and publications, and an international database. And so the only thing we needed to make this happen was we needed money from benefactors. And we called on Arthur Hertz, who's a legend here. He was a great benefactor for the University of Miami and Jackson Memorial Health System. And Arthur jumped at the opportunity to train individuals in this manner. We also then asked the Michelle Wolfson Senior Foundation, and now more recently, the Eberhard Grube, a major thought leader in structural heart disease, was enamored by the idea of international training and the quality of our trainees. And so he gave a naming gift for the program. Now, we also had unrestricted educational grants from several of the major strategics. And this is the group of individuals we trained in the last 9 years. And you recognize many of them. 2 of them are faculty at Jackson Memorial Hospital. And, Venkatesh, who's my current fellow. Diego is going to be our new fellow next year. And so we're very proud of what this group has done. And this is a wild ride. I mean, there's multiple situations with us enjoying different meetings and different events, meeting with major thought leaders, working hard in the different surgical laboratories and interventional laboratories throughout the world. There in Salamanca. Here you can see Camilo and Joao celebrating in the cath lab. This has been fabulous. Our fellows have also been very involved in academic pursuits, and they have 39, in the last 5 years, 39 publications, 16 book chapters, and 1 book in structural heart disease. This is the Eberhard Grube International Heart Disease Training Program of the International Medicine Institute. So the TAVR growth continues because after the original approval, there was in the next decade approval for use in intermediate risk patients after randomized trials showed that it had equivalency to surgery, and then low risk patients in which a randomized trial showed that it was as good or perhaps even better than surgery in many patients with calcific tricuspid aortic valvular stenosis. So this is how TAVR's gone since then. And so here in 2012, less than 5,000 cases. Let me explain this busy slide to you. This is surgical aortic valve replacements, all surgical aortic valve replacements, regardless of how it's used for. This is isolated aortic valve surgical replacement. And then these are surgical valve replacements for double valves, surgical valve replacement with cabbage, and surgical valve replacement with aortic root replacement. And you can see that TAVRs began to grow and grow and grow. And in 2018, it surpassed all surgical valves as the most common form of valve replacement in the United States. It now accounts for 60% of all valve replacements in the United States. And in the world, there's been now 1.5 million valves done. Multiple technologies have been developed, and these are just the evolution of some of the devices and other valves that have come and gone, including one that was a mechanical expansion, one that was a inflatable expansion. We did research with both of these at University of Miami. This is our most recent valve that we did the first one of yesterday here at the University of Miami. This is still in European trials. Beautiful new technologies that have helped us be able to make the procedure much safer and more predictable. These suggest the evolution of the Sapien valve, the original Cribier valve, now has gone through multiple generations. The sizing of the delivery catheters have become much smaller, and the actual guiding catheters have become much more accurate and proficient. Now, the reason why we do TAVR has also changed dramatically. Initially, it had to be patients with extreme or high risk. And then by the middle of the decade, the intermediate risk patients went up. By the late decade, we now were starting to introduce low risk patients. And now we're doing about a third of each over time. Median age hasn't changed much. It's still a disease of the elderly. Our median age is 79. You can see that the lower risk patients are a little younger. Still, the great majority of the patients that are done for surgical valve replacement are not bicuspid valves, although bicuspids can be done with TAVRs. The young bicuspid valves that are very calcific and so forth, we still don't have a good valve for. The procedure is done almost exclusively femorally now, because we can pre-treat vessels and post-treat vessels so that we can deliver them from the femoral arteries, and also the vessels. The delivery systems are much smaller, and so very few are done with alternative access. This is an interesting new way to use TAVR also, which is it's called TAVR in SAVR, and it's using the TAVR valve inside a failed surgical valve. So you have a surgical valve that was implanted, let's say 10, 12 years ago, it's calcified. Instead of having to do the dangerous redo surgery, you can put a TAVR valve inside that SAVR valve. And then so here there's about 5,000 of those done yearly. And you can see that this little blue number is starting to go up. And this is using TAVR for failed TAVR. So in patients that had previous TAVRs, 8, 10, 12, 15 years later, they can have calcification of the valve and may need a second procedure. And we can put a second valve inside of that. So 5.7% of all TAVRs are now done with TAVR in SAVR. Surgical TAVR mortality has gone down significantly. This is in hospital, which was 6%, now down to 1.2%, 30-day 2.1, and 11% is 11%, partially because these are, 1 year is 11%, partially because these are very elderly patients and very sick patients. So it's still an 11% death rate, but significantly less than it was in the past. In-hospital pacemakers have gone down somewhat with different delivery systems and awareness of how to implant the valves more safely. Medium length of stay has gone down from 6 days to now 1 day or 2 days in the nation. And stroke, which was thought to be one of the things that would hold back TAVR, because in the very early TAVR trials, it was a question as to whether there was more stroke. When this was actually properly analyzed, there was actually less strokes than there was in surgery. And on top of it, we've continued to lower the stroke rate as the devices have gotten better, the techniques have gotten better, and the operators, and also the patients that we're treating are less sick. We're starting to introduce cerebral protection devices in 2018. The verdict is still not out on how much they change outcome. Now, going on to the next technique, patent foramen ovale closure for cryptogenic stroke. This is a transesophageal echo. Patients having microscopic bubbles injected into their venous system. And you can see that bubbles are going in from the right side to the left side of the circulation. This is to mimic what we think happens with paradoxical embolization and paradoxical stroke. Now, I've been doing, in the center, we've been doing PFO closure for a couple of decades. But the Amplasser PFO occluder, which is a device that was made specifically for the PFO, was CE marked in 1998. This wasn't approved in the United States till 2016. But in the interim, we still treated patients with closure, but we couldn't use specific devices for the foramen ovale. We had to use ASD devices, and we had to also do clinical trials. So we did clinical trials trying new devices in patients that had recurrent cryptogenic strokes despite therapy. Now, the two devices that are now approved are the PFO Amplasser device. It's a double disc type device, one disc in the left atrium, one disc in the right atrium. And the cardioform device is also double disc, but not as metallic and a little more cloth-like. Multiple other devices are being studied throughout the world. Now, this is what's made the technique into an outpatient procedure. And we can do this with local anesthesia and very mild conscious sedation. The patient's actually conscious during the procedure. Is we put a microscopic catheter into the left atrium. This is the catheter, which is intracardiac echo. This is 8 to 11 French in size. And you can see the gorgeous pictures we can take of the inside of the cardiac anatomy. Here is showing that aneurysmal septum of a patient. And you can even see the shunt going across the septum. So this is the procedure done. This is the actual guidance. We use fluoroscopy also, but the real guidance is done with intracardiac echo. You can see one disc on the left side. Now we're putting a second disc on the right side. Here we're just making sure that the device is nicely positioned and that it's covering the whole hole. Here's the fluoroscopic image of that. Here's the device is released. You can see what it looks like once it's closed and what it looks like fluoroscopically. So the trials that allowed for PFO closure to be widely accepted as a method to prevent recurrent stroke were 3 different trials: the RESPECT, the REDUCE, and the CLOSE trial. All of those are published in the September 14th, 2017 New England Journal. And it's one of your reading lists. And you can see that in all these trials, the treatment group had a much lower incidence of recurrent stroke than the treatment group, which was antiplatelet therapy alone. The FDA approved PFO and GORE devices in 2016 and 17. And globally, there's been 56,000 cases done, 12,000 in the US. Moving on to mitral valve edge-to-edge repair. This ingenious technology of seeing if we can put a clip in between the 2 leaflets of the anterior and posterior leaflets of the mitral valve in order to reduce regurgitation. It was conceived as a transseptal device that could be aimed and positioned in a way that you could precisely put a clip in the places that were leaking, in the spot that was leaking in the valve. And this very fantastic engineering of the device allowed you to be able to position it and move it into a precise location. A clip is actually a little teeny clip inside the heart, but it looks huge in these pictures. This was, again, the first one was done in 2003. By 2008, the CE mark had been approved, had approved the device for use. In 2013, the FDA approved the mitral clip for patients with degenerative mitral valve disease. This is mainly myxomatous mitral valve disease. Now, this was because the trial that had been done, the randomized trial against surgery, had only had 26% of patients with functional mitral regurg. And we'll talk about that in 1 second. But you can see that in multiple other trials, there was a lot of functional mitral regurg, but the FDA still thought it was unwise to approve it at that moment. So this is how this procedure is done. And so this is the device under fluoroscopic view. This, you can see it in the positioning itself in the at the mitral valve. And you can see also how the valve looks after it's released. And by looking at this image, you know how the hell do you know where you're at? And the way we can tell that is by this fabulous 3D TEE imaging, which allows us to see here the anterior and posterior leaflet of the mitral valve. That's the orifice. We can precisely position the clip in a way that we can grab the leaflets and position it right where the regurgitation is. You can see the clip here after it's been released. This is in 3D. We know we have what's called a tissue bridge, where we've united the anterior leaflet and the posterior leaflet of the mitral valve. These two orifices now is what the mitral valve is, and this is called an owl eye look. It looks like an owl is winking at you. And you can see that the regurgitation has been dramatically reduced from before the clip was reduced. This is actually one of our patients that was in the unit, couldn't get off pressors with severe mitral regurgitation. It had a massive infarct with a pseudoaneurysm. And this is after clip. His MR reduced almost completely, and he was rapidly being able to be taken off of pressors, and he was discharged. So the problem with only doing it for degenerative mitral valve disease is this, and this is where you only got a class 2B indication for this technology, and only limited to degenerative mitral valve disease. In 2011, we had published a paper that showed that the largest number of patients with mitral regurgitation in the United States were actually functional mitral regurg, or type 3B Carpentier class abnormality, where the valve was normal, but the heart muscle, the heart was expanded so that the leaflets couldn't coapt in the middle. The one that surgery is done most for is for myxomatous mitral valve disease. And this is the one that's also called degenerative mitral valve disease. And it's the one that surgically is treated beautifully with mitral valve repair. And so the group of patients that we're only being able to treat was a sliver of the total number of patients that were too high a risk to have any type of surgery, because mitral valve repair can be done with great success and low morbidity. So this group, however, the group with functional mitral regurg, there's really been no papers that have shown that surgical treatment changes major outcomes in these patients or improves their survival. Now, in the rest of the world, though, they thought that there was enough evidence. And so there were 830 centers doing mitral clip in the world, 50 in 50 different countries. There were 1,050 published articles in 2018, 50,000 procedures, 97% implant rates, and 64% of them were for functional mitral regurg. And in the US, we weren't able to do it until this fabulous trial, the COAPT trial, which was a trial that took patients with severe functional mitral regurgitation, 3 to 4 plus MR, and they were treated with heart failure experts in guidelines-directed medical therapy. When they were at maximal tolerated dose, if they still had symptoms, they were randomized to clip versus guidelines-directed therapy alone. And this is the results of the study for all-cause mortality, including some of the crossovers. But either way, you can see this is at 3 years. You can see that there's a huge difference between the two groups. This enviable p-value that all of us would want to have in one of our studies, it was dramatic. Only 3.4 patients needed to be treated in order to have a reduction of 1 event. And this is the first trial I've ever seen have a standing ovation in a major medical meeting when it was presented. They also showed that progression towards the need for LVAD and transplant was reduced largely if you added a clip. And so with this data, the FDA approved the clip for functional mitral regurg. So how are we doing in the United States? Right now, there's 507 centers, 13,000 procedures done. This is almost all the patients are very elderly because we had a predominance of degenerative mitral valve disease. As we're going now with functional, this age is going to start dropping in the U.S. Okay, what am I talking about here? So here you can see that in 2014, almost all patients were degenerative. This has gone down as we started recruiting functional heart failure patients for the mitral clip. And I think these two numbers are going to cross probably this year or the next year, where there'll be more functional done than degenerative. The in-hospital mortality is really low. It's only 1.6%. Still, that 1 year mortality is 20%, as these are very sick patients. In-hospital 30-day and 1 year stroke rate is really low. It's 0.5. This procedure really, unless there's a technical error, really doesn't cause a stroke. In-hospital and 30-day mitral insufficiency, it is very good at reducing severe mitral regurgitation to moderate or mild mitral regurgitation, but still in about 8% of the patients, we still have some moderate to severe mitral regurgitation. Although a lot of these patients feel significantly better, even though we aren't able to demonstrate it by echocardiography. In hospital and 30-day mean gradient is a little bit elevated. So we're trading severe mitral regurgitation for mild mitral stenosis, which is the same thing we do with mitral valve surgery, valve replacement, and mitral annuloplasty. But about 24% of the patients have what we consider mild mitral stenosis after the procedure. Going on with the mitral valve still, one of the things that can also be done now is we talked about TAVR in SAVR, where you can also do TAVR or a transcatheter aortic valve in the mitral position for a failed mitral valve. And this is a bioprosthetic mitral valve that was put in 12 years earlier and had failed. And now, instead of having to do a second surgery, we're able to put here a Sapien 3 valve in the mitral position. Since the procedure started being done transeptally, it has fantastic outcomes and is being done in about 410 centers in the US. This is mitral valve in ring, which is in a person that's had an annuloplasty ring for mitral valve repair. In most of the rings, we can also put a valve inside if the valve fails later. And one thing that we haven't been able to make as good a progress with is using the mitral valve in severe mitral annular calcification, although there's a lot of work being done with this. It doesn't seem to be working as well and with higher risk and less long-term good outcomes. So this is an area which I've been extremely interested in, is where can we make a valve that that can be put in the mitral position, specifically made for the mitral valve, rather than a TAVR in the mitral position. This is the multiple different valves that have been developed for this. Almost all of them have been, of these are all transapical approaches, where it's done with a beating heart, but with a transapical approach through the apex. The one that I've worked with is Tendyne. And just to tell you quickly the story of Tendyne, because it has a launch, the company was launched off of a patent of mine for left ventricular reduction in 2010. Once the company was founded, we changed the focus and directed it towards mitral valve replacement instead, and used the idea of using tendons or tethers for anchoring the valve. We did our first acute in man trial in 2013 in El Hospital Italiano of Asunción, Paraguay, with Adrian Ebner, who is one of the principal first in man trialists in the world. with the European team and a US team and a Tendyne team, and guided by the International Medicine Institute. And so since our acute in man trial, the first compassionate use were in 13, and then permanent implants as part of trials in 14. It received CE mark in 2020. And now multiple cases have been done in the world. 1,500 cases have now been done in the world. It's still not approved in the US, but clinical trials are ongoing. I have actually one of my former structural fellows is part of the clinical trial in Tallahassee. And so this is the first valve to receive CE mark or of any kind or any approval for the mitral position. Now, I really believe that the future of mitral valve therapy won't be transapical, but it'll be transeptal. And these are what's called stage delivery. And these are devices that are currently in clinical trials in the US and in Europe. And you can see what they do is they put an annuloplasty ring basically with a catheter. And then after putting in an annuloplasty ring, either through the aorta or transeptally, they put either a balloon expandable valve or a specifically designed self-expanding valve. So this is the future probably of mitral valve replacement. Left atrial appendage closure is a very important technique to reduce stroke in patients with chronic atrial fibrillation, probably underutilized in our center. We've known for a long time that patients that have atrial fibrillation, when we see clot in their heart with transesophageal echo, 91% of the time we see it inside the left atrial appendage. And the reason for that is the left atrial appendage is a very rough internal portion of the left atrium, which is much smoother. And this is pectinate muscle. And also it's like an appendage of the atrium that's a sac that's totally static when you're in atrial fibrillation. So if you want to, if you're a clot and you want to form in the left atrial appendage. So this became a very attractive target for interventional therapies with the idea, can we put a filter in to prevent clots from forming and getting out of it? And so this was the first Watchman device. You can see that it has a cloth covering. With the cloth covering, there's a rapid endothelialization, and you basically seal off the left atrial appendage. Now, this device was first piloted in 2002 and 2005. It received CE mark approval. There were 2 large randomized trials in the US and registries before the FDA gave approval in 2015. When it did give approval, it gave it for atrial fibrillation in people that are not capable of taking oral anticoagulants because of bleeding or other major problems. And this is a meta-analysis of those 2 randomized trials, just to show you what kind of data we had. So overall efficacy was about the same. Total ischemic strokes, total strokes was the same between warfarin and the Watchman. There was a little less, there were a little more ischemic strokes, especially in the early phase, because many of these were little bubbles as the technique was just maturing, and we didn't have a good way of removing all the bubbles from the device that we were putting in. You can see that the difference is still there if we take out the procedural cases, but it's nowhere near as strong. And there was significantly less hemorrhagic strokes because the patients weren't on anticoagulations, less unexplained cardiovascular deaths. These were probably hemorrhagic strokes also. And major bleeding was less with the Watchman because the patients weren't taking anticoagulants. It's reasonable. So these are the 2 approved devices in the US right now. This is how it's approved as a class B2B indication. And it can be used in patients that are at increased risk for stroke that have contraindications to anticoagulations. This one is the Amulet device. It's a little different. It's a double disc, a double device, which has a 1 piece to inside the left atrial appendage and a little disc to close it totally on the outside. Mike Dial is very enamored with this device and is using a lot of them. And this is the new Watchman device, the Watchman Flex. We like both devices. I don't think that there's any data that's compelling between one or the other. There's multiple devices that are still in investigation or have been used. And so we'll be seeing many more. And in the US now, you can, after you put in the device, you can either use a short course of anticoagulation with aspirin, followed by 6 months of dual antiplatelet and then aspirin alone, or you can go straight on to dual antiplatelet therapy, followed by aspirin. It's the clinician's decision, depending on the patient case. So it's very safe to use in multiple patients, even those that have GI bleeding. Right now, there's 108,000 cases done, 63,000 in the US. And there is much more to come, but obviously this is a 50-minute grand rounds. Just to touch, give you a little taste. This is what's going to happen in the tricuspid valve. And the tricuspid valve, once called the forgotten valve, is now being courted by multiple companies. And multiple devices are well underway. There's three that are real close to US approval. This one was just presented, it was just published in the New England Journal, the data from the Triluminate trial. It's like a mitral clip, but specifically designed for the tricuspid valve. This is like another type of mitral clip, the Pascal device, slightly different. In its delivery system also has a spacer, and this is real close to acceptance. And this is a valve that developed specifically for the tricuspid valve, the Evoke valve. They can also be used in the mitral position, but it looks like it's going to get a tricuspid approval probably next year. So thank you very much for allowing me to give you this rapid tour. And I think that we've made a case that international cooperation in innovation and treatment is required in this field. So,
Eddie, thank you very much. That was a real tour de force and a beautiful summary of what's been happening here and in the world and your influence on it. It's almost, in Miami, structural heart disease is synonymous with Eddie DeMarchena, and we're grateful for what you've done for our patients and for the institution. Maybe I could begin by asking somewhat of a naive but maybe practical question. Are we any closer in dealing with, let's say, patients that are have infective endocarditis, that have valvular disease that we see oftentimes due to intravenous drug use or other interventions, especially immunocompromised patients? Are we any closer not to being able to send those people to surgery and being able to do something less invasively in the cath lab to help them?
Yeah, it's a really good question. It's a frustrating area. You just had one this morning in the CCU. We were looking at one of these patients, and it's very complex. I can tell you what is done as far as clinical trials showing superiority in any technique. We don't have good clinical trials, but we use all kinds of therapies in these patients. Carlos Alfonso has been doing a lot of cases with the angiovac to extract these infected clots from the tricuspid valve. And we've been able to do that effectively and allow some patients to get a much better outcome over time. We've done cases which have had endocarditis and are dying of aortic regurgitation. And we've done palliative TAVR in those patients, with the idea that if they're still infected, then if we can get them from the original situation, we can buy time. And we've also done mitral clip for patients with like partial flail valves, where they have a severe regurgitation. And they're still not totally treated for their endocarditis, but are not considered surgical candidates. We put a clip in the valve to try to reduce the total amount of regurgitation. We can't do much for tears inside the valve. So for those, we can't do much at all. And the big fear is obviously you're putting a prosthetic device in a person which is already infected, and you're afraid that you're going to infect those. So this is still a limitation to therapy that hopefully will be addressed in the future.
Thank you. Any other questions or comments for Dr. DeMarchena? Well, thank you, everybody, for attending Grand Rounds today. Thank you, Eddie, for a great presentation. I remind everybody to look in the chat for the link for your CME and MOC. Hopefully, we can answer these multiple choice questions from this lecture. Thank you, Eddie. And everybody have a safe and wonderful day. I remind everybody next Monday is the quarterly faculty meeting. Be there, and we'll have Grand Rounds as usual next week. Everyone have a lovely day.
Thank you very much.
Thank you.